I guess limitations of the current targets we use for deep brain stimulation and movement disorders. Right now, the way that we target deep brain stimulation is based on what we call ACPC coordinates. So we identify the anterior commissure, identify the posterior commissure, and use that as a very rough atlas of where our DBS electrodes should be positioned. And so there's certain coordinates that we target for the VIM nucleus of the thalamus for central tremor, other coordinates that we target for the subthalamic nucleus, and a third set of coordinates we target for the globus pallidus. But this is a very rough approximation of where our DBS targets are and should be. And so there's been a lot of effort to replace these measurements, these coordinates, with a more accurate or precise image-guided treatment. And so that can involve new MRI sequences that allow us to see neuroanatomical borders or tracks that we don't normally see that can help us identify the subthalamic nucleus in an individual patient based on iron, for example, or identify the globus pallidus or the VIM based on connectivity or neuroanatomical boundaries. And so moving away from let's just measure out these coordinates, the number of millimeters from the midline that we want to go, and instead use advanced MRI metrics to target our electrodes more precisely to where we want them to be. And then kind of along with that is where do we actually want to be? And so moving from coordinates to better visualization of our target regions is step one, and there's a lot of focus there. Step two is to say, hey, maybe the regions we've been targeting are not even the correct therapeutic target. There's no rule that says that the ventral intermediate nucleus of the thalamus, defined histologically, is the right place. There's no rule that says that the subthalamic nucleus is actually the right place. It might be right at the border of the subthalamic nucleus or a track going in or out of the subthalamic nucleus. And so, one is, can we better visualize the region we think is the target? And then step two is, can we better understand what our target should be in the first place? Because it might not even be the neuroanatomical region that we've been going after. And underlying both of these motivations is improving clinical outcomes. So while we have very effective treatments for DBS, for tremor, or many of the symptoms of Parkinson's disease, not everybody gets better. Not everybody gets better to the same extent. Some people have these miracle responses to DBS. Other people have very little response to DBS. And we think at least part of that is where our DBS electrodes ended up. And slight differences, millimeters, can have very big effects on patients' clinical outcome. And so our clinical motivation for refining our therapeutic targets and improving DBS is to optimize the therapeutic benefit for every patient that we treat, rather than seeing this large heterogeneity in response. And then the last clinical motivation is there's a lot of symptoms that we don't treat well with DBS. And so Parkinson's disease involves rigidity, dyskinesias, tremor, symptoms that we can treat very well with DBS, but it involves also depression and memory trouble and balance difficulty and gait impairment. And we don't treat those symptoms well. And again, it might be because we haven't found the right therapeutic target for any of those symptoms. And it might be very different than the therapeutic targets we currently are using.